Welcome to the Critical Care Obstetrics podcast. My name is Julie Arafeh, and I'm the Simulation Director for Clinical Concepts in Obstetrics. Today I'm here with my partners, Stephanie Martin, Medical Director at Clinical Concepts in Obstetrics, and Suzanne McMurtry Baird, Nursing Director at Clinical Concepts in Obstetrics. This is our second podcast of responding to questions from our listeners. We had put out a request for questions, and we heard from so many of you. We so appreciate your time in listening to our podcast and coming up with these wonderful questions. So we're going to concentrate today on our questions about preeclampsia. So we'll start with the first question. What are the potential management options for preeclampsia without severe features and without a consistent pattern of blood pressures? No critical range blood pressures, and most captured pressures are normal. Are there alternatives to 37-week inductions when we see the above pattern?
So I think this is actually a common question from patients. They may not want to deliver at 37 weeks. Our initiatives at trying to prolong pregnancies closer to the due date has really been successful. There was a huge swing in the pendulum from the days when people would not bat an eye to schedule an induction at 36 or 37 weeks for patient preference or whatever it may be. But sometimes it's been a little too successful where people are now fearful of delivering when delivery is actually indicated. So let's talk a little bit about preeclampsia and why we make this recommendation. First, you need to establish the diagnosis of preeclampsia. If they have preeclampsia and there's no severe features, then the current recommendations are to deliver around 37 weeks. The reason for this, I tell people nothing good ever happens from preeclampsia except a delivery. And I say that a little tongue-in-cheek, but the reality is this is a progressive and unpredictable condition where things can become quite severe and quite risky in a very short period of time. So the longer she remains pregnant, the greater the chance we're going to encounter a problem with mom or baby or both that was potentially preventable by delivering. So I like to use a lot of analogies, and when I'm explaining to my patients, I'm like, think of it as like wearing a seatbelt, okay? So you can get in a car and not put on your seatbelt. It doesn't mean that something terrible is going to happen to you when you drive. But the faster you go and the longer you do it, the greater the chance that something is going to happen where someone gets injured. You might get lucky and have nothing happen, but the longer you prolong a pregnancy with preeclampsia, it's like the seatbelt. It's like you're driving at 100 miles an hour without a seatbelt, and you might be fine and you might not, but why are we taking the chance? That 37-week mark is simply the point where the maternal and fetal and neonatal risks kind of balance. So the risk of the neonate being born at 37 weeks is pretty low, and the risks of complications by prolonging the pregnancy relative to what we're gaining for baby and avoiding a preterm birth or an early term birth or whatever you want to call it are higher. So it's just a sweet spot of balancing it. Patients can refuse anything they want to refuse, but they need to be appropriately counseled about the risks and benefits of staying pregnant versus delivering at 37 weeks. And it's current standard to recommend 37-week delivery for a patient with preeclampsia without severe features. What are your thoughts, Suzanne?
Well, I would rather induce a patient at 37 weeks who's still, got some, what we might think of another analogy is some reserve. She doesn't have multi-system organ failure symptoms at this point. She still has a disease that begins with the placenta. And I think that that's a key point, that preeclampsia is a disease of the placenta, and that it's not going to get any better. So would you rather induce a patient at 37 weeks I know her cervix is probably not going to be ripe, but I think enough of you have seen a lot of 39-week inductions lately too. And a lot of times their cervix is not very ripe either. And that patient at 37 weeks, though, has no, fetal growth restriction, and she doesn't have oliguria at this time. She doesn't have elevated liver enzymes and low platelets and things of that nature, versus a 39-weeker who has all of those factors. So, and still doesn't have a ripe cervix. So I say, go ahead. I would be all for that. And I think sometimes we get pushback. The docs get pushbacks from nurses on these patients, but really it's important to follow those guidelines.
Yeah, and to kind of follow up on I couldn't agree more, Suzanne, completely with you. And to follow up on the wording that the person, I'm assuming this is a nurse, but that was asked in this question was really focusing on the pattern of blood pressures. So where you don't have severe range blood pressures, most are normal, but you don't have a consistent pattern. The pattern of blood pressures does not dictate your management. You either have first of all, you have preeclampsia or you do not have preeclampsia, and then you have severe features or you do not have severe features. Having the diagnosis tells you you're at risk for significant maternal fetal neonatal complications that are worsened if the blood pressure is severely abnormal. But having blood pressures that are not severely abnormal, yet having the diagnosis of preeclampsia is a high-risk situation. So don't be falsely reassured that everything's going to be fine because she doesn't have severely abnormal blood pressures.
Exactly.
I remember working in the clinic when I was working with medically complex patients, and we would get patients in that had clear criteria for preeclampsia, send them over to the labor and delivery unit, and I would invariably get a call. We've put this patient to bed, and now since she's in bed, her blood pressures are all normal. Can she go home? No. I think it's normal for their blood pressures, once they're in a different position, to potentially change, maybe lower a little bit because they're not standing up. So I think position has a lot to do with those inconsistent patterns in blood pressures, and making sure you're getting a good measurement, that you know what position the patient's in. Because if you're lying down, you're obviously going to change your cardiac output a little bit. So your blood pressure might be a tad bit different.
Yeah, that's a great shout out too for that correct way of taking a blood pressure. I got to tell y'all, this medical assistant at my internal medicine doc's office, she is amazing, like at taking blood pressure. She's like, uncross your legs. I want you to take some, a couple deep breaths, and I want you to bring your arm up at your heart level. I mean, to the textbook. And I love her so much because she knows how to take a correct blood pressure with the right size cuff, everything else, no talking. And have you emptied your bladder? All of these things that she goes through. But I'm telling you what, I've seen a lot of incorrect blood pressures because people weren't taking them correctly.
Yeah, and I've seen patients where, I've seen them either in the office that day, that night, they're in the hospital either with a new diagnosis of preeclampsia that they didn't have that morning. I remember one patient, we were evaluating her for discharge home, and before I could finish writing her orders, because she was ready for discharge home, still pregnant, we thought it was preeclampsia without severe features. We were going to manage her expectantly at home. And I get called back to the room within about an hour for severe right upper quadrant pain. She's now HELP syndrome. I mean, preeclampsia is unpredictable. And so this is about risk management, not necessarily normalizing and making it low risk when it's not. It just means not severe.
I used to say and put my arms and an X across my chest, and that's how I'd illustrate those patients that, like you said, Stephanie, that maybe you've just seen them, and then all of a sudden their severe criteria, they kind of cross over, and they make that switch so quickly, and it's shocking. And I've had patients die that had that scenario happened to them where they were seen that day or the day before, and the next day they had it was a maternal mortality, and that will wake you up, and it will alarm you to where I guarantee you the next time Julie calls you from the office, which, by the way, I wasn't in charge those days, I hope.
No, you
When you
weren't.
call. And I had no beds on the unit, and I was trying to figure out where I was going to put patients, but I digress. Anyway, you won't question that again, okay? When you've seen that scenario. When they come in at 37 weeks, you're like, I'm so glad they're here.
Yeah, exactly. Next question. Atypical preeclampsia. Is it preeclampsia when there's not a single severe or even elevated blood pressure? Is that atypical preeclampsia?
Yeah, so this is an interesting question because we each looked at this question and interpreted it a slightly different way. So let me just kind of address my interpretation of it. First of all, there's no such thing as atypical preeclampsia. There's preeclampsia with and without severe features. That's it. There's no atypical preeclampsia. And if you don't have an elevated blood pressure, you don't have preeclampsia. Now, the criteria for preeclampsia start with blood pressure. Then everything else gets added on to it. Are they severe? Are they not? There is such a thing as HELP syndrome without high blood pressures. So approximately 20% of patients with HELP syndrome will never have an elevated blood pressure. So you must be suspicious about a hypertensive disorder of pregnancy and draw labs if you think it's possible. So there's no such thing as atypical preeclampsia. There's preeclampsia with and without severe features. You can have atypical HELP syndrome, and you can have HELP syndrome without hypertension. But first, you have to have hypertension.
And see, and I took the charge nurse approach too, because I've been in, here's the scenario, just like what we discussed. You have 10 beds and they're all full. And you have several patients in triage. Some are in labor, and some are in the waiting room coming into triage. So you know what your day is going to be like. And Julie calls you from the clinic, and you're trying to find that bed for a patient who's now going to have a medical induction. So that's the way I viewed this question, that they got some different pressures when they got her up to the unit. And now they're questioning the diagnosis. Could this be atypical preeclampsia? So, or use that term. So that was the way I interpreted this question. So we hope that either way that we answered that question for you, and know again that these patients do need to be delivered if they have preeclampsia.
The next question is an interesting one. Repeat rounds of magnesium for preeclampsia. So I'm wondering, is this how many rounds of magnesium? Or I think, Stephanie, you thought it may be discontinuing the magnesium and the patient. I don't know. What do you guys think about this question?
Well, I thought it as the patient came in, was diagnosed with preeclampsia with severe features, which is magnesium sulfate is indicated for those patients with severe features. So that they got the initial round of MAG, and maybe they were admitted to an antepartum unit. Now they're going to be induced for preeclampsia with severe features. Do you need to start the MAG again? And my answer would be yes. You do. Again, remember that magnesium, and the purpose of magnesium sulfate administration is to control or prevent, I think depends upon what data that you look at and the studies that you look at, because we've definitely seen studies where they were on magnesium sulfate and had adequate levels, serum levels, and still were having seizure activity. So it was more of not a control situation of the seizure activity, but we're actually preventing or controlling it, I guess, in as far as the severity of it. So you weren't preventing it, but you were controlling it. So I don't know. What are your thoughts, Stephanie?
I think you're talking semantics. I think I want to make sure the listeners hear that magnesium is indicated to prevent eclampsia. Exactly what it does and how it does and what's happening in the brain is up for debate, but you should give magnesium for patients with severe features. Now, we're not going to give multiple rounds of magnesium just because they have a diagnosis of preeclampsia. However, there are some key times when patients should be on magnesium. If they have severe features and you're doing your initial evaluation of the patient to determine if they're a candidate for expectant management or if they require delivery, they need to be on magnesium while you're making that decision if you think they have severe features. Then many times we decide that they do not need to be delivered because they are preterm and they do not have an indication for delivery. I'll go over those in a minute, but they don't have an indication for delivery. And so we're going to hospitalize them. I will repeat, we are going to hospitalize them until delivery takes place, either because they've reached 34 weeks gestation or delivery is indicated for another reason. When delivery is happening, they need to be on magnesium again. And that magnesium needs to start when the induction process starts. Basically, once the delivery decision is made, magnesium is resumed. And it continues until they have their baby, in the operating room during the surgery, if they have a cesarean, and for 24 hours of postpartum, period. No discussion, no debate. That's the current guidelines. That's the current recommendations. And then there may be times where you're trying to figure out if they need to be delivered and you start it again, but that's unusual. Most of the time, it's going to be their initial evaluation period. You decide that they're a candidate to be watched in the hospital with severe features. Then at time of delivery, you make a decision. You're going to start the mag again, keep it on until they have the baby, and 24 hours postpartum.
I was wondering if the question came about as the patient had mag sulfate during her induction or delivery and went home and then came back in again. So the question would be then, would mag sulfate be indicated at that point? Or maybe she didn't have the diagnosis of preeclampsia before. I guess if you're saying repeated, then that would be the scenario. I mean, I guess that could have been the question as well.
Yeah, I agree. It's not a lot of detail in the question, but I would say anytime you think somebody has magnesium, has preeclampsia with severe features, they need magnesium sulfate to prevent eclampsia. And that could be a postpartum readmission. Or if they present with eclampsia postpartum, then they need to be on magnesium. The farther they get out from birth, the harder it is to know exactly what is happening. Right. But most maternal fetal medicine docs are going to recommend erring on the side of caution and giving them magnesium if you think preeclampsia with severe features is a possibility while you're figuring it out. And then if you decide that that's not the likely scenario, you can stop the mag. But you want to try and prevent and avoid a seizure while you're trying to figure out what's happening with your patient. Now, indications for delivery with preeclampsia with severe features, pretty straightforward. We're talking about refractory hypertension, refractory headache, refractory right upper quadrant pain, pulmonary edema, stroke, myocardial infarction, HELP syndrome, renal dysfunction, oliguria, etc. So there's going to come a point where what you're doing is not working and your patient is not responding to your therapy. You can't treat the headache. You can't treat her pressures. She's going to get delivered. I mean, you cannot keep someone pregnant forever. Even if they're periviable, you're going to do your best to safely keep them pregnant and prolong the pregnancy. But at some point it becomes unsafe. And that's where those recommendations come in. It's just time to deliver at that point. And we got a question about that refractory hypertension coming up in a minute.
I think that's an important point that you make, is that in this situation with preeclampsia, as opposed to other disease state, let's say cardiovascular disease, The impetus of this whole disease is the placenta. So you are not going to get better until the placenta is out of the patient. And, so many times we kind of criticize in other disease states the rush to delivery, but in this situation, delivery is really important because that is the definitive treatment.
Yeah, and I always say, you know, you are never benefiting the mother by keeping her pregnant with a diagnosis of preeclampsia, ever. You are always taking maternal risks with her health, short and long term, and her mortality risk by keeping her pregnant. The reason to keep someone pregnant with preeclampsia is to benefit the baby. And at some point, the risks to mom may outweigh any benefit to baby. And that's where the guidelines come in. Because if mom's going to stroke in order to get an extra 24 hours for baby, what have we gained? Right? So mom is always at risk with preeclampsia, baby too, for that matter. But the farther along they get in the pregnancy, the less the weaker the argument to prolong it, because it's going to benefit baby in some way.
Right. Well, that kind of leads us into our next question. I think the statement, the meaning behind this question is a review of the treatment of preeclampsia, including blood pressure and neurologic protection.
Well, I think many of you have blood pressure algorithms, hypertension management protocols in place. In fact, I think from my experience, and Stephanie, I think you would agree with me that many of you have adopted those openly and are utilizing those effectively. We'll talk about the refractory part in a minute. But the neurologic protection, I'm assuming what you're talking about is for the fetus and starting mag sulfate. And that would be, again, in that preterm period where you are and possibly giving that mag sulfate for neuroprotection. And I want to make a point with that. I think from a nursing perspective, when you have that order and maybe you're not seeing severe features, but she's got preeclampsia moving more towards that severe line, and they give neuroprotection mag, then you need to know why you're giving the mag, okay? Because the protocol for neuroprotection often is the same as it is for when you give mag for preeclampsia with severe features. I've seen some differences in some hospitals, but the fact is, as a nurse, I need to know why they're giving it. Why do I need to know? Because I'm the one talking to the patient. I'm the one in there talking to her and saying, this is the rationale for giving this. And I have seen and read in depositions where nurses were asked, why were you giving the mag sulfate 2 days before? And the nurse said, well, I assumed it was because she had preeclampsia. Well, it was for neuroprotection. And so knowing the difference, I think, is important. And yes, that may be a scenario, is that they are giving mag for neuroprotection and then again looking for other signs, or maybe trying to get betamethasone in and then deliver her.
Yeah, outcomes are better for babies born preterm who are exposed to steroids and are exposed to mag. So if we think there is a significant risk of delivery preterm, particularly in the next 48 hours to 7 days, then we're going to try and expose the baby to steroids and magnesium for improved neonatal outcomes. We don't always know, so it's an evaluation of how high we think the likelihood is. Somebody who does not have severe features has a much lower risk of needing to be delivered compared to somebody who has severe features. So pretty much all patients with severe features, we're going to make sure that they get steroids and magnesium. In a severe feature situation, you're kind of killing two birds with one stone. It's for both reasons. However, she might be 35, or let's say 34 weeks, and you're delivering her. The mag's not for the baby, it's for mom. So you can have a dual indication, but that's why we're giving it. And I agree with Suzanne. It's important that you understand what's happening with your patient. She may not have severe features, but may be on MAG because they think she's going to deliver for something. Maybe she's got a growth-restricted baby with abnormal Dopplers and preeclampsia without severe features. We're giving her MAG for the baby, not because of preeclampsia, but it can be confusing. So ask questions, understand what's happening with your patient.
That's the nursing process, remember? When you're developing that plan of care, component of the nursing process is to understand the whys and ask questions if you don't understand the plan of care. And again, you're going to be the one that's there 24/7 with the patient, that you need to know the whys.
Okay, well, in that light, confusion, there's some confusion about where IM injections should be given. And I'm assuming this is mag sulfate. Giving mag in the buttocks is no longer recommended. Nursing culture needs to be changed. When you need to inject IM mag, where do you recommend it be injected?
So I had not heard that giving injections in the buttocks was contraindicated. So I did a little research on this and really found not very much research on it at all, or where to give injections and any kind of scientific study. And there are still recommendations for the four sites, but we did find some research saying the femur, giving it in the leg injections, that there could be greater chance of nerve injury, and that site was no longer recommended. I could not find any research of not giving dorsal gluteal injections and ventral gluteal injections. And I'm assuming the dorsal gluteal is what the comment or the question was about. But so if you have that literature, I would love to see it. And so please email it to us, and I'd love to review it. But I couldn't find it in the literature. Stephanie?
Yeah, this was total news to me. I think for me, the take home here is twofold. Number one, we recommend giving IM mag in the dorsogluteal region if IM mag is indicated. It's the largest muscle. This is a large injection. It's very painful. It doesn't really make sense to give it somewhere else. So I see no reason not to give it into the upper outer glute region. Part two is, wherever you're giving an intramuscular injection, you must do it in the proper form and technique. You need to understand your landmarks and know where to give it to avoid injury, because it is possible to have injury, and the feared injury is nerve injury. And I've actually known a physician colleague who was permanently disabled from a vaccination in his arm, and he was no longer able to operate because of an injury from an improperly administered injection. So you have to have respect and know exactly where, so that you are minimizing the likelihood of an injury. You cannot completely prevent everything. There's risks and benefits to everything. But if you got to give IM mag, give it in the dorsogluteal region, in my opinion.
And again, if there's something that we don't know, and we don't know everything, and you don't either, and nobody does, and I have no ego in any of this, I'd love to see what literature you're speaking of, and send it to us.
Absolutely. That's part of why we like doing this so much. We're constantly learning and challenging how we think and how we view things.
Yeah.
But I would assume that for something like this, it would be very easy to find a guideline or a recommendation about this. What we did find basically was saying that the anterior upper outer thigh region was the highest risk area compared to other intramuscular injection options. So you got to know your landmarks and minimize risk.
Yeah, and some of that was done. Some of the research that we found was done on cadavers, but it's interesting, and I want to respect the question. So I would love to learn if you have that those data. I'd love to look at it.
Our next question is fairly complete, so I'm going to read it verbatim. I am an L&D nurse in a low-risk hospital and recently had a patient who was unresponsive to the hypertension protocol. She was a chronic hypertensive who developed severe pressure postpartum. We went through the labetalol followed by hydralazine and restarted the protocol 3 times. Her oral nifedipine was increased from 30 to 60. Our providers did not seem to know what to do with her. What are your thoughts? Eventually, her pressures began trending down, but we had about 8 hours of severe range pressures as we were constantly treating.
So I'll just open this up here with, first of all, thank you for the question and for having it be so complete. I think this is a scenario that happens a lot. And I want to start with the first comment. Low risk hospital. That doesn't mean your patients are going to stay low risk. Okay? This patient was already high risk because she was chronic hypertensive, and she quickly became critically ill. So this question, the nutshell here is failure to recognize and act on critical illness. This patient should have been, her care needed to be escalated. And we're going to talk through how to escalate, both as a nurse, as a physician, within your system, whatever. But her care needed to be escalated to either a more appropriate unit within the facility or to a more appropriate facility. Because she was, this is refractory hypertension. And it sounds as things ended well, but that's luck is not a plan. This is lucky that everything ended well. This is a very, very high risk situation here.
Yeah, I give this scenario in our academy because I think in OB, we think when we have that hypertension algorithm that we work through it. And again, as in this scenario, you may rework through it and you still have these severe range pressures. If you go through that algorithm one time and you still have severe range pressures, the patient's critically ill. And that's the recognition part. And that's where we need to say this patient needs a higher level of care. Whether that, again, is in the ICU that may be within your hospital, whether it is calling an RRT and having that decision be made at that point, or whether it is transferring her to another OB hospital, depending upon, if she's still pregnant. But in this scenario, with a postpartum patient, if you had an ICU in your hospital, it may be that she is managed at that adult ICU with OB co-management. So the OB, and if you have MFM access, they need to be involved in managing that patient because she is critically ill. And in chronic hypertensive patients, this happens quite frequently, especially in the postpartum patient, as she becomes postpartum. And she starts absorbing that amount of volume within the placentas delivered and the volume that she's had during delivery and in the postpartum period. And you're going to see some pretty outrageous volume as well as your systolic pressure especially go up. And I've seen patients that were not managed in a critical unit, but have to be managed in an ICU postpartum when they have those, especially in a chronic hypertensive patients. They can have some wildly high blood pressures.
Yeah, so let me talk a little bit about what should have happened medically, and then we can talk through some of the approaches you can take if the team is not recognizing that something has to change. So to follow up on what Suzanne was saying, this patient, first of all, she's postpartum. You have every antihypertensive agent available to you to treat her hypertension. It doesn't have to be labetalol, hydralazine, and nifedipine. But you cannot continue giving her medications that are not treating her severe pressures. So typically she would be admitted to an intensive care unit. We'd get put in an arterial line. You would give her a continuous infusion of something like nicardipine or whatever is necessary. You could even try an ACE inhibitor. You can do a whole bunch of different things, but you have got to, you're keep doing the same thing, expecting different results, and you're getting the same result. In the meantime, the patient is at risk for stroke, cardiac decompensation, myocardial infarction, detaching her retinas. Like, you can have all kinds of complications happen here. So she could lose her life because of this. Or be permanently disabled. So something has to change. Now, you're at the bedside. Let me talk from the physician perspective. So I'm the physician at the bedside, and I can't get the patient to respond. Well, I'm going to ask for help. Okay? I need to get help. What I'm doing is not working. I've reached the limits of what I know how to do, or that I'm comfortable doing. Or maybe I just want somebody else to put eyes on the patient. I can either call a rapid response team. This patient probably met criteria for an RRT. Or I can call a consult, an immediate consult, not come see the patient in the morning, either from the hospitalist in the hospital. They deal with hypertension all the time. From the emergency department, from an intensivist, from a maternal fetal medicine specialist if I'm not an MFM. You have so many options of how to get help. Every low-risk hospital has an emergency department. Every low-risk hospital has an internal medicine doctor available to you to consult. So you've got people that you can talk to. Even if it's on the phone, look, she's not doing anything. What do I do? They're like, are you crazy? Get her in the ICU, right? There's things that you can do to break you out of that. So don't just keep doing the same thing. But Suzanne or Julie, like, you're the nurse at the bedside, and the doc is not, like, they're set on this path, and it's clear to you something's got to change. What do you do? How do you deal with that?
I would refer right back to, and you know where I'm going with this, the checklist. I would refer right back to that checklist, because on your checklist, with your preeclampsia hypertension protocol, it should have a space on there where you follow up. If this is not working, you call this maternal fetal medicine number at this tertiary center, or exactly what Stephanie said. And I have seen, I don't know how many times, where the physician is thinking. They've got so many things. They have cognitive overload because they're trying to think of every single thing to do. And the nurse just leans over and goes, would you like for me to call the maternal fetal medicine consult? They haven't even thought of that because they're so busy running through some of these other protocols. Okay, should I try this? Should I try that? Thinking about what they need to do. Sometimes it just takes that one other person to go, would you like for me to call the intensivist? Would you like for me to call whoever it is on your sheet that's going to be appropriate in your institution? So I think that is one of the things that maybe nurses aren't comfortable doing. But again, you get validated by what is on the checklist, because this is what is recommended in your facility. It should be based on evidence. It's a good plan to follow. So you should have every confidence in going to that physician and saying, let's go ahead and try, or I'm happy to call. This is the next step on the algorithm or on the checklist. I think that's a very appropriate way to handle it from a nursing perspective.
Yeah, and I would probably have to go and sit in timeout for a few minutes, and then I would take some really deep breaths, and then I would put on my leadership hat, and I would have a private conversation to say, this patient is outside of our scope of, of services on this unit. So if you don't know what a scope of service is, we have a podcast on that, and I would refer you back to that. But if you're a rural hospital or a low risk hospital, as it's defined, and you're managing this critically ill patient in your unit, she's outside of your scope. And you have every right as a nurse to say, I'm not comfortable managing this patient. And here is why, with the facts. She's outside of our scope. And if you aren't comfortable changing the management plan, then I am going to go up my chain of communication, or I am going to call an RRT. your choice. And I would be very professional about it. And because there's no sense in, screaming and yelling or anything like that, but very professionally just have a conversation, just to say, I'm not comfortable in managing the patient, and I need to go a step further, and I'm going to call this person, or I'm calling an RRT. And I would be honest and upfront. And I do that anytime I've gone up chain of communication or chain of command, some of you may call it that. Then I have informed the physician that I was doing that, and here is why. Never, I haven't had anybody, object to that, but it's another set of hands, it's another set of eyes, it's another brain.
But Suzanne, you're confident and have a lot of experience, and I suspect that you were pretty confident and could speak your mind even early in your career. So what would you say to a nurse who's newer, or maybe very intimidated, or maybe this physician is not so approachable? Like, what would you say to them? They know they're in their gut, it's not right. They can't quite put their finger on it. They're intimidated. What do we do?
Yeah, I think that you go find the Suzanne on your unit. And in a low risk hospital, that may be the house supervisor. And a house supervisor is going to know that this patient is outside of their scope and range for that particular scenario. And I think that they're well trained to take those things into consideration. But this is a patient safety issue, and if you approach it from a patient safety issue, approach and say, this is, I'm concerned about her outcome, her well-being, that we need to do something different. I think, again, it's hard. It is hard to do that, even for me. I mean, a lot of people think I might be confrontational, and I can be. Quite honestly, I can. Just ask one of my son's girlfriends the other night. I was very upfront. Put it that way. I wasn't confrontational, but I'm very upfront. I don't have a problem asking questions or seeking answers to things or speaking my mind. You're right. But I think that there is going to be somebody available for each nurse, whether that's the charge nurse or the house supervisor, that it's still what would you do? In other words, if this were your daughter or your best friend or your sister, what would you want the nurse to do?
I've dealt with this so many times in simulation and just been horrified at, number one, how nurses can get treated when they speak up. And number two, horrified at what they didn't speak up about. So we have spent a lot of time trying to work with nurses in an interprofessional group in simulation to get them comfortable to speak up and to give them some distinct guidelines on what is the proper way to do this. And as you said, you must go to that person and tell them you're going to go up the chain of command. That is basic respect to that person and the role that they are trying to fulfill. There is no faster way to bust your team wide apart and not have trust and respect in your team than to go behind someone's back. I do not recommend that. So you must go to that person and tell them exactly what Suzanne said. This is what I'm going to do, and this is why I am going to do it. And exactly as you said, we've found when we ask nurses, what is it going to take to help you? What would help you speak up? What do you need to be able to address this issue that you're seeing? And it was always, I need somebody else with me. So you need to get someone, even if they're just standing with you while you're talking, that helps a lot. These types of situations can be practiced in simulation. And what was really, I think, one of the most, I think, impactful part was the response the physicians had to that. Was like, you have to speak up, encouraging the nurses. This is what you have to do. You have to speak up. If this is what's going on, we need to hear it. And one of the physicians that I have worked with probably the most, has on every time when he walks on the unit. He's got a little list that he gives the people he's working with that day. And the last thing is, don't let me screw up. So I think hearing that validation from other physicians is really helpful. Is that going to mean you're never going to get yelled at, or you're not going to be spoken to disrespectfully? Probably not. But at least you understand that this is the right thing to do, and you can leave the unit that day knowing you did the right thing.
Yeah. And I mean, again, it's not easy. I remember my very first time having to do this, and I was a new grad, and I was confronting a nurse who'd been there for a long, long time. And I don't know, for some crazy reason, I was in charge, which is insane. But I had to confront this other nurse about an assignment. And it was, my heart was in my throat and everything. But it's what's necessary for patient safety and that treatment at that time. And granted, in some scenarios, you don't have time to do that. I mean, and in some scenarios, especially if it's a smaller hospital, there may be only one doc that does OB there. So that chain is very short. But again, the important thing is improving your culture also by practicing and having these conversations ahead of time. I think is so key. And it really will improve your ability to do that when it goes live.
Yeah. And I just want to make a kind of another comment about what might have been happening in this situation. These kind of things are, in my experience, more likely to happen when the patient's asymptomatic. So it's very likely that this patient was, quote, feeling fine. She probably didn't feel great, but she's probably not complaining of a whole bunch. So it made it easier to normalize the abnormal and not have a sense of urgency, rather than if she's writhing in pain or something along those lines. But Julie, kind of to follow up what Suzanne was saying, it seems like this would be the perfect case to simulate.
Yeah, totally. This should be simulated. I am a big believer in taking things that happened on the unit and running them through simulation, not to shame or blame, but to figure out why it happened, and then to determine what we should have done differently, or what can we do differently? What took us down this path instead of the path that we should have taken?
Yeah, because I read into this question at that with that nurse. I read into this situation. It was like an episode of that show, What Would You Do? Which, by the way, I would fail that show because I would do it. I would interrupt somebody eating and tell them, you need to quit yelling at that. And I've done those kinds of things. But so again, but putting that new nurse or a less experienced nurse to OB, or somebody that is not comfortable in escalating their concerns or speaking up, I think is key also for them to learn and that experience, learn how to, deal with that experience, and to have that conversation before it really happens, and doing it through simulation would be so helpful for that nurse.
Exactly. Well, that's the end of our questions. Any final thoughts from anyone?
Well, I don't know that I'll have any girlfriends dating my sons anymore. So after I made that comment, and I didn't, that's my only. Sorry. It was more of a conversation and not a confrontation. So.
No, knowing your boys are going to find somebody just like you. They're going to bring that one home.
Oh, no. Yeah, but that's always fun, Okay, again, I'm off topic. Y'all need to rein me in, but I've had a dog day, so I've got 2 sleeping dogs beside me, so we can keep going if y'all want.
Well, this was fun. We'll keep going. We've got lots more questions, so we're going to have more podcasts with more topics, because we've got a lot more questions that you guys posed, which are really great. It helps us kind of understand what you're hearing from us and how we can make it more relatable and more attainable at the bedside. Like, how do you translate what we're talking about to the bedside? So we love your scenarios, and, keep sending questions in.
Keep sending the questions in, and, give us the details that we might need to, in certain scenarios, what we might need to know about how to answer that. But this was great.
Definitely keep those questions coming. And thank you for listening. Don't forget to subscribe and leave us a review. You can learn more about the Critical Care Obstetrics Academy and our company at www.clinicalconceptsin.ob.com. You can also follow us on our Facebook page, Clinical Concepts in Obstetrics, on Twitter at OB Critical Care, and on Instagram at Critical Care OB. Email us or send a direct message for suggestions on future podcasts.
This podcast was produced by Austin Baird. Are you looking to create a podcast? Please email me at podcastnashville@gmail.com. That is podcastnashville@gmail.com.